Good morning, everyone, and welcome to the ASGE, the Biliary session. Today, we have a pleasure having Dr. Brooke Lessing from the University Hospital, and then myself is Toss from Bumrungrad Hospital in Bangkok. So today we have many good studies that we are so excited when we review the abstracts, and then we saw that this year we have much more information that going to be beneficial for the audience. And today I think we should start now.
Just a few housekeeping. We are asked to invite all of you to move up to the front if you are so interested in order to keep the engagement alive. And then I just wanted to remind you guys that in addition to asking questions at the aisle microphone, that you can also submit questions electronically through the mobile app, and we will be doing our best to answer those. We have a number of great talks, and then afterwards we'll have a 3-minute Q&A session, and we invite the speakers after your talk to join us on the stage afterwards.
Right.
Okay, so it is my pleasure to introduce to the stage Dr. Vinay Dier to talk to us about the prospective randomized comparison of pre-cut papillotomy and endosonography-guided rendezvous procedure for bile duct access in patients with distal CBD obstruction and difficult CBD cannulation.
Thank you, chairpersons. Am I audible? Okay. Okay, so we presented this trial briefly in the presidential plenary, a randomized comparison of pre-cut and EUS RV for bile duct access in patients with difficult biliary cannulation. No conflict of interest. As you are all aware, difficult biliary cannulation is a marker for prolonged ERCP times and also adverse events. There has been a lot of data in the past decade regarding this, and the guidelines from ESGE defines difficult biliary cannulation with the rule of 5-5-2, that is 5 times attempts, 5 minutes, and 2 pancreatic duct cannulations. Once you have reached the status of difficult biliary cannulation, you go for advanced procedures, and pre-cut is the usual technique that is employed with very high success rates at expert centers, but with an increased rates of pancreatitis. We proposed almost a decade back EUS RV as an alternative, and this was a retrospective study we published 12 years back, where we showed that the first session success of EUS RV was higher than that of pre-cut, although the adverse event rates were similar. So we continued from that, and we decided let's do a randomized study. And so this study took us 11 years to complete. 2013 we started. The aims were simple: compare the rates of technical success and adverse events in patients with difficult biliary cannulation and distal malignant biliary obstruction. Treatment success was defined as completion of requisite endotherapy in 1 session. So usual inclusion criteria: age more than 18 years, malignant distal biliary obstruction, accessible papilla, difficult biliary cannulation. We did not keep the pancreatic duct of the ESG because ESG came much later. We started this study much earlier. So we had kept more than 5 minutes and more than 5 attempts. Exclusions were previous ERCP, sphincterotomy, bleeding tendencies, and inaccessible papilla. Sample size calculation was done. It's similar to one of our previous studies, assuming 85% success rate at first attempt. 208 patients were required with a 10% difference in success rate. So this was the sample size calculation. All consenting adults with malignant distal biliary obstruction fulfilling the inclusion criteria were offered these. A lot of them opted out because EUS RV is a new procedure, so that's a problem. Outcomes, as I told you, technical success, adverse event rates, time for procedure, and numbers of days of hospitalization. So this was the flow chart. 4,082 patients consented. We had 208 difficult biliary cannulations, 5%, and 104 in each group. This is the patient population. No significant difference in any of these parameters. Most of the patient had carcinoma head of pancreas and cholangiocarcinoma. These are the results. So there is no significant difference in technical success rate. RV was mildly higher, not significant. No significant difference in adverse event rates. If you saw the pancreatitis rates, it bordered on significance but did not reach significance. So maybe we needed more patients to reach significance. Time for procedure, I think this was expected, was significantly higher for rendezvous. Hospitalization was not significantly different in the two groups. So majority of RVs were done with the transduodenal route. Few were done with the transhepatic route. There was no significant difference between the two approaches. If you look at the pancreatitis in the two groups, you see there was no severe pancreatitis. And I think that is because we did not try more than 5 minutes. So mild PRP was predominant. 2 patients in the pre-cut group had moderate pancreatitis. And none of these patients died. So mild and moderate pancreatitis, not very significant increase in hospital stay also because of this. We looked at the failed procedures and we found that in rendezvous there were 3 groups mainly. One was obviously patient where the papilla was within the diverticulum, so pre-cut was practically impossible. Second was type 2 flat papilla where we had difficult biliary cannulation but pre-cut was difficult. And third was a large ampullary cancer. For failed EUS RV, there was only one factor, a CBD diameter more than 2 centimeters that caused failure of RV. So this is the first prospective randomized study comparing these two procedures. We have a fairly large sample size. Definition was in line with ESG criteria except the PD part of it. Recently, there have been 2 more trials, one from the Hong Kong group. It's a retrospective study where there was a mix of benign and malignant cases. There was significant difference in the technical success rates. RV was significantly better, and there were significantly higher bile leaks. There was another study from India. This was only for benign patients. No significant difference between the two procedures. The limitations of our study, it's a single center study. We did not use prophylactic BD stents, and the study was conducted by endoscopists who are highly experienced in the two procedures. So the two techniques did not differ significantly in terms of technical success rates or adverse event rates. Time required for procedure completion was significantly shorter with pre-cut papillotomy. This study suggests that pre-cut is may be the primary option for difficult biliary cannulation, although we may do a larger study and see if the pre-cut pancreatitis rates are highly significant. EUS RV could be the first option in a few situations as I described before. Thank you.
Thank you, Dr. Deer. Congratulations on a really excellent study.
Thank you.
We're opening the floor to questions.
Dr. Deer, wonderful talk. A couple questions. Now with distal malignant biliary obstruction, obviously transmural drainage is an option, perhaps not the beginning of this trial. How would EUS RV fit into the algorithm where choledochoduodenoscopy and HGS are options for distal malignant biliary obstruction?
Thank you for the question. So our algorithm is still very old-fashioned. We follow the approaches that were described in GIE, I think 2016 and 2013. if papilla is approachable and we fail ERCP, we go for rendezvous rather than go for EUS BD directly. If papilla is not approachable, then we go for EUS BD directly.
Makes sense. And then one technical question. For rendezvous, is your preference to use a 19 gauge needle or a 22 gauge needle?
A 19 gauge needle.
Okay, thank you.
Yeah.
Good morning, everybody. My name is Mohammad Asghar. I'm a GI fellow. Thank you so much for very good talk, Dr. Dir. So I have a question about the inclusion of the patients. Were they all referred from outside hospital, or did you guys recruited them from your own center? And if they were recruited from your own center, so how did you did the randomization after failing right there? And then deciding on to do the next procedure. And if they were referred,
yeah.
And if they were referred, did you guys try to do conventional way and see if you were successful, because there might be a difference in the expertise?
Thank you. So it's a very, very good question. So our practice is such that a vast majority of these patients are referral patients. If the patient had failed ERCP outside, we attempted it from at our end, and then we defined that this is a difficult biliary cannulation. So I don't think there are any patients who are generated directly by us, because it's a tertiary referral center. Almost all the patients are referred from outside.
I'm a top Chuck Cleveland. Vinay, kudos on tour de force, just getting something like this accomplished and done and persisting. Question I had, you may not be able to answer completely because you're not powered for that as an outcome, but there's been this suggestion in the literature that it's the difficult cannulation part and not the pre-cut sphincterotomy part that causes pancreatitis. But the reason your EUS group is a very controlled group about the difficult cannulation, and that's why they got that 1.2% rate of pancreatitis, whereas your pre-cut group seems to have a higher. It's not statistically significant, but I think, and you might agree, that pre-cut is a little risky, at least that's the suggestion. And even though you may not be powered, maybe because of that pancreatitis concern, I mean, should we be going more and more towards EUS, especially with the first author suggesting we have other techniques and other ways to do it?
That's a fantastic question. In 1998, I was one of the first ones to write a letter in GI endoscopy saying that pre-cut is not to blame for the pancreatitis, and there were subsequent studies which suggested that probably we were trying too hard for too long, and that's why pancreatitis rates were going up. However, here we kept a level playing field in our study. 5 minutes, 5 cannulations. So we did not try harder. And it's obvious that this group had a higher, and you are right. See, the study is adequately powered. This is, I think, the largest randomized controlled trial in the field of EUSBD. We haven't had a randomized control. But still, we could not reach significance. So probably for practical purposes, I think we have shown that pre-cut is, yes, there is a higher incidence, but most of them are mild, and I think that again is because we are not trying long enough. We are finishing early, and we are going for pre-cut early, and that's why probably pancreatitis does happen, but it is mild. So, and it did not increase the hospitalization rates or mortality. So the message that the study gives is, yes, probably pre-cut increases the pancreatitis rate, but if you are not trying long and troubling the papilla with repeated attempts, probably it's mild and it should not really matter. That's the message I guess we are giving.
Thank you, Dr. Deer. In the interest of time, I think we're going to have to move on, but there will probably be time at the end to ask more questions.
All right, so the next one, we're going to move on to the second abstract, the randomized clinical trial comparing ERCP versus ERCP plus EUS guided gallbladder drainage In non-surgical patients with symptomatic choledocholidiasis, the midterm analysis. We welcome Dr. Emmanuel Perez Miranda for the talk.
Good morning. It's a pleasure to share this session. I'll be presenting this midterm analysis of our randomized trial comparing ERCP versus a combination modality of ERCP plus EUS-guided gallbladder drainage for choledocholitis in high surgical risk patients. Gallstone disease is very prevalent in the general population. Up to a fifth of subjects will develop associated symptoms, and once a patient develops gallstone-related symptoms, more than a third will require a hospital admission within 2 years of that symptom unless cholecystectomy or some other intervention is performed. That is actually the rationale for cholecystectomy in practice, which is so often a prophylactic surgery. In the elderly, the incidence of biliary events is highest, whereas the presence of contraindications, absolute or relative to surgery, is also higher. EUS-guided gallbladder drainage with LAMS is a valid alternative, has proven superior outcomes to percutaneous cholecystostomy and comparable outcomes to cholecystectomy. We therefore hypothesize that we could, at the time of ERCP with stone clearance, associate in tandem under the same sedation a second procedure, EUS-guided gallbladder drainage. We designed a prospective randomized trial conducted at 8 Spanish centers in which inpatients admitted for choledocholitis, age 75 or higher, Charlson index 4 or higher, and in which cholecystectomy was not deemed indicated, were eligible for randomization. Exclusion criteria: concurrent acute cholecystitis or acute pancreatitis, an emergency out-of-hours procedure or performed by a non-expert operator, incidental finding of malignancy unsuspected before the procedure, the presence of surgically altered anatomy, or the lack of an EUS window to safely access the gallbladder. So patients first underwent ERCP with sphincterotomy and stone clearance, and at the completion, balloon catheter was used to fill through the cystic duct the gallbladder with contrast. And then all patients underwent diagnostic EUS with a linear EUS scope to assess for anatomic suitability. And in those who had an accessible gallbladder, a sealed envelope was opened and randomization took place. And the study group underwent EUS-guided gallbladder drainage. Typically, transduodenal access was recommended, and no pigtail or interventions were recommended. However, the final decision on these technique aspects was left to each participating endoscopist. Follow-up was planned for 12 months at 7 days, usually as an inpatient, and then at 3, 6, 9, at 12 months. Conducted by telephone interviews by a dedicated research nurse who was blinded to treatment allocation and who would discuss or consult with a gastroenterologist in case of any events, who was also blinded to the treatment allocation. The primary outcome measure was hospital readmissions, either related to symptomatic gallstone disease or procedure or stent-related adverse events. Secondary outcomes, technical and clinical success, overall adverse events, all-cause admissions, overall survival and quality of life, Kaplan-Meier curves, and the log-rank test were used to assess for the primary and main secondary outcomes. 918 patients were screened. A large number of them were excluded. Some of them were too young. Some others had concurrent cholecystitis. The surgical candidacy was not ruled out in a huge number also. 26 had altered anatomy. The expert endoscopist was a DDW somewhere else in 75 cases. 11 patients were performed as urgent. 4 patients had coagulopathy. A large number declined consent, and 128. And then, after all of these inclusion-exclusion were fulfilled, we found unsuspected malignant disease in 4, cannulation or stone clearance failed in 4, and those were excluded. And in a further 4 cases, there was no safe window for gallbladder drainage. Eventually, 74 patients were randomized, equally distributed. The baseline features were comparable, mean age 89 or 88, sex distribution, Charlson index 5.5. The rate of prior biliary events was around a third in each group. Most common diagnosis was cholangitis, 2/3 in either group. And then the mean hospital stay was 7 and 8 days. CRP was slightly higher in the combined group, but not statistically significant. So for our result, the duration of the combined procedure was slightly longer for the combination group, 22 minutes versus 19.7. The rate of sphincterotomy, sphincteroplasty was different. The duration of gallbladder itself was 11 minutes. Transduodenal access and 10x10 lamps were more common. The rate of adverse events was no different, 13 versus 16%, mostly bleeding in the combination group, and a perforation. All of these adverse events resulted from ERCP, not from the gallbladder drainage. And then the risk of readmission at 1 year was significantly higher, biliary-related readmission significantly higher in the combination group, in the ERCP group, 25.7% versus 5.7%, with 8 readmissions, mostly related to cholangitis. 2 patients underwent cholecystectomy, and the 2 admissions in the combination group were bleeding that occurred after discharge. No difference in the 1-year mortality rates, 12.6 versus 23.1%. And again, the overall readmission was no different, although in the first 3 months, the number of readmissions was significantly higher in the combination group, tumor, cardio, respiratory, and other issues. So in conclusion, in non-surgical patients with symptomatic cholelithiasis, performing EUS-guided gallbladder drainage as a tandem procedure together with ERCP reduces the risk of subsequent gallstone-related admissions without an increased risk of adverse event or prolonging index hospital admission. Thank you very much for your attention.
We have time for maybe one question, if there are any.
Yeah, nice study. I'm Dr. Rajesh Puri from India. So the message should be that patient with the gallstone disease can go for an EUS guided gallbladder drainage. Is that right? Either they are symptomatic or asymptomatic. Because what you have shown that in a group where the EUS gallbladder drainage was not done.
By definition, in our trial, all of these had symptomatic cholelithiasis. That would qualify as symptomatic gallstone disease, not just cholecystitis. So this is 80, 90-year-old patients coming to the hospital with a stone, some other comorbidities. We know they're not going to be subject to cholecystectomy. And we take the opportunity, since the patient is already on the table, sedated, consented, we offer them an additional procedure in case the gallbladder is favorable to prevent relapses. So the only thing we're not doing different is lowering the threshold for gallbladder drainage, because cholecystitis was an exclusion criteria. So that was asymptomatic gallstone, but with symptomatic gallstone disease.
And what you did when the gallbladder was not distended? How you approach the gallbladder? Because
when there was a safe window, as perceived by the operator, in In other words, we will not go the full length to try and drain the gallbladder at all costs. So, but having put that as a safety, as a precaution for safety, we only had to exclude out of 4 patients out of the 75 that we screened. So, and we also, as I tried to explain, we did ERCP first, and after sphincterotomy is completed, we use a stone extraction balloon and try to feel through the cystic the gallbladder, so to make gallbladder drainage easier. So we blow up the gallbladder with saline and contrast, transpapillary through the cystic, remove the duodenoscope and go ahead with the echo endoscope. So we try to make an easy procedure with usually the freehand technique.
Again, require a very expert hand. It cannot be done in the...
Some of these procedures were done by the fellow, so under supervision. So our fellows are very expert.
Thank you.
Really quick, Raj.
Congratulations on your study. I think that though you excluded the patients that were most going to benefit from EUS guided drainage, which is the cholecystitis patients. I don't know, my interpretation is that biliary sphincterotomy is sufficient if there's symptomatic coloductal lithiasis. If they have a dropped gallbladder stone in the bile duct, that adequate sphincterotomy should allow that stone to pass. Very few patients had recurrence for cholecystitis and required cholecystectomy later. So I'm not sure that you included the patients that would benefit most from gallbladder drainage, which is the cholecystitis patients, which you excluded.
I absolutely agree with you. These patients are those who benefit the most. That's why we excluded from randomization, but not from gallbladder drainage. So we routinely drained those. But this is prophylactic gallbladder drainage. So they were excluded from the study, but not from gallbladder drainage. And as for the efficacy of just sphincterotomy and stone clearance, it is effective, but if you add gallbladder drainage, the efficacy is higher. This is a midterm. There's still a lot of things that we need to look at, but numbers are holding up.
Thank you.
You're welcome.
Thank you so much, Dr. Perez Miranda. I would like to welcome to the podium Dr. Jessica Fritsch, who will be talking to us on the impact of EUS-guided coloduodeostomy versus transpapillary endoscopic biliary drainage on the intra- and post-operative outcome of pancreaticoduodenectomy, a multi-center propensity score match study.
Thank you. My name is Jessica Fritsch. I'm a PhD candidate at the gastroenterology department in the Amsterdam UMC. And I'm happy to be here to talk about pancreaticoduodenectomy after EUS-guided biliary drainage when we compare that with ERCP. And I will give this talk on behalf of all the co-authors, but also the Dutch Pancreatic Cancer Group and the Dutch Pancreatic Cancer Audit. I have nothing to declare. I don't need to tell this public that EUS CDS is increasingly performed as an alternative for ESCP. However, most current studies excluded patients with a resectable disease, and therefore data on subsequent pancreaticoduodenectomy are still limited, which often leads to the discussion with your surgeon if it's really safe to perform EUS CDS in a potentially resectable patient. Moreover, previous nationwide study showed more postoperative pancreatic fistulas in patients who underwent ERCP with a plastic stent versus a metal stent. And this is presumed to be caused by the fact that a metal stent induces some fibrosis of the pancreas, which would protect against postoperative pancreatic fistulas, which is also not the case when you perform EUS CDS. So we performed a nationwide retrospective cohort study, and we included 8 hospitals that had performed both pancreaticoduodenectomy as well as EUS-guided biliary drainage. We included all patients that underwent preoperative endoscopic biliary drainage between January 2020 and December 2022. We used a prospective cohort, which is a mandatory audit for all hospitals in the Netherlands that perform pancreatic surgery. However, postoperative outcomes not necessarily reflect possible interoperative difficulties that the surgeon experienced. So we also asked the surgeons to fill out a short survey after the resection. Primary endpoint were major postoperative complications, defined as a Clavin-Dindo score of 3 or higher. So patients either underwent re-intervention or needed an ICU admission. Overall, postoperative complications and surgeon experience were included as secondary endpoints. We included almost 1,000 patients that underwent endoscopic preoperative biliary drainage. 42 of them underwent EUS-guided biliary drainage, and 895 underwent ERCP. Baseline characteristics were more or less comparable. However, we did see a little bit more pancreatic cancer and less cholangiocarcinoma in the EUS CDS group. Also, more patients in the EUS CDS group were treated in a very high volume hospital. Surgical characteristics were more or less comparable as well. However, we did see a shorter time to surgery and shorter operative time in the EUS CDS group. And to be able to increase the comparability of the groups, we performed a matched 1-to-3 propensity score analysis, which induced overall balance between the groups. Moreover, we only included patients who underwent ERCP with metal stent in the ERCP group in the matched analysis, considering this is the current optimal treatment. However, despite the balance, the time to surgery and operative time remained significantly shorter in the EUS CDS group in this analysis. So coming to the results, we did not see a real difference in the major postoperative complications, or at least not significant, and not higher in the EUS CDS group. We did, the overall postoperative complications were about 65% in both groups. And when we look at postoperative pancreatic fistula, clinically relevant grade B or C, the results did not really differ as well. In the matched analysis, results were more or less comparable. The major complications in the ERCP group were a bit lower in this analysis. Maybe this reflects the exclusion of the plastic stents. Other results were also comparable in this matched analysis. When we only include patients that underwent primary EUS CDS, and we compare this with the patients who had who ERCP was intended, we actually see very promising results. However, there were only 17 patients that underwent primary EUS CDS. And when we look at the pancreatic fistulas, we actually had 0 patients in this group. As I said, this doesn't necessarily reflect any potentially technical difficulties that the surgeon experienced. So we asked the surgeon after performing a surgery in patients who underwent EUS CDS how they experienced the surgery, and the majority said the surgery was not complicated or only slightly complicated by the stent, and in the patients that they experienced some difficulties, they mostly reported some inflammation, infiltration, or adhesions in these patients. So in conclusion, we did not see an increased risk in complications of pancreatic duodenectomy when you compare EUS CDS drainage with ERCP, and only few surgeons reported substantial difficulties performing the resection. However, we should mention that it remains an exploratory study, and we had a little, although quite large, we had still a small sample size. And the results in primary EUS CDS sound very promising. So we believe this study paves the way for future randomized controlled trials to include resectable patients as well. And these studies should report both post-drainage as well as post-operative complications. So then I really hope there's still time for some questions.
So I think just for the sake of time, one question.
Congratulations on this nice presentation. What was your hypothesis to explain
We assessed patient characteristics, procedure factors, and early adverse event focused on peritonitis. We defined peritonitis as the patient with all findings on the slide occurred within 7 days after EUS, resulted in prolonged hospitalization or additional procedures. First, fever or the elevation of inflammatory markers in blood test. Second, new onset abdominal pain. Third, new fluid correction in the abdominal cavity on CT. And method of statistical analysis is shown here. We evaluated factors associated with peritonitis after HGS by multivariate logistic regression analysis with a stepwise word selection method using p-value. Now let's proceed to the results. First, I will present the baseline characteristics of the study patients. A total of 188 patients were included, with none excluded. The most common cases of biliary obstruction was pancreatic cancer. Patient with duodenal invasion. A patient had duodenal invasion and ascites in 63% and 18% respectively. And let's move on to the table 2, which details the procedure factors of HGS. 90-gauge needles were commonly utilized. The median diameter of punctured bile duct was 6 millimeters, and the median distance to hepatic parenchyma was 28 millimeters. The median quantity of aspirated bile was 25 milliliters. Dilation with electronic cautery catheter was performed in 46% of cases. And antegrade stenting was added in 30%. Prostate stent and SEMS were placed in 60 and 128 patients respectively. Procedure time was 32 minutes. Moving on to the table 3, I will now present the early adverse events. Peritonitis was observed in 7%, including 2 severe cases based on guidelines of ASGE. Additionally, pancreatitis, cholangitis, and cholecystitis were occurred following HGS. And this is a key slide of the current study. Multivariable logistic regression analysis revealed that presence of duodenal invasion and the diameter of punctured bile duct less than 3 millimeters independently increased the risk of peritonitis after EUS-HGS. Now let's discuss the findings. 2 tips: bile aspiration of more than 10 milliliters during EUS-HGS and maintaining a distance to hepatic parenchyma at 25 millimeters or more have been reported to be effective in prevention peritonitis after EUS-HGS. In our study, the median quantity of aspirated bile was 25 milliliters, and the median distance to hepatic parenchyma was 28 millimeters. So most of our EUS-HGS procedures met these prevention criteria. However, peritonitis after EUS-HGS occurred in 7% of cases, including 2 severe cases. The presence of duodenal invasion and the diameter of punctured bile duct less than 3 millimeters were identified as new risk factors for peritonitis after EUS-HGS. We hypothesized that duodenal invasion may obstruct bile and food outflow, increasing that internal pressure of the stomach and promoting bile leakage into the abdominal cavity. And a small bile duct diameter may increase the risk of contralateral bile duct injury during puncture, further elevating the likelihood of bile leakage. In conclusion, duodenal invasion and the small diameter punctured bile duct may serve as risk factors of peritonitis after EUS-HGS. Thank you for your attention.
And I think just for the time constraint, we're going to move forward to the next question. And then for those who have questions, please feel free to send the questions through the app. So the next one, we welcome Dr. Nicholas McDonald from Thomas Jefferson University Hospital to present on the topic of long-term follow-up in patients with and without gallbladder LAMS removal.
Hey, everybody. My name is Nick McDonald. I'm the Advanced Endoscopy Fellow at Thomas Jefferson. And today I have the honor of presenting on behalf of my co-authors our study for you guys. This is like my first presentation doing this, so my goal is just to not pass out as I talk about our study. So EUS-guided gallbladder drainage is a growing option for patients who are poor surgical candidates. As some of the previous speakers and randomized trials have shown, there's a advantage to doing this over percutaneous approaches. And now we have an FDA-approved indication in the US to use lumen-opposing metal stents for gallbladder drainage. There's no currently agreed upon duration to leave these lumen-opposing metal stents, as some of the previous speakers have talked about some early data of longer-term outcomes and questions of what do you do with this once you place the gallbladder lambs. There's a lot of variation in practice patterns across the country, with about 50% leaving the lambs in routinely, or routinely removing the lambs, and 50% leaving the lambs in place indefinitely. We aim to assess the outcomes of patients undergoing endoscopic gallbladder drainage with and without lambs removal who had at least 1 year of follow-up. This was a multi-center retrospective study of 4 U.S. academic medical centers. All patients underwent endoscopic ultraside-guided gallbladder drainage with at least 1 year follow-up. And we defined clinical success as successfully treating the indication for the gallbladder lambs in the first place. In terms of demographics, we had 40 patients in the study. The mean age was 66.8 with a standard deviation of 13, and 53% were female, so a good balance between men and women. In terms of indication for the lambs, our most common indication was acute calculus cholecystitis, which was 11 patients, about 27% of our cohort. Malignancy-related cholecystitis was number 2 at 9, and then acalculous cholecystitis, chronic cholecystitis, and failed ERCP or internalization of a cholecystostomy tube were some of the lower indications. In terms of results, most common lamb size place was 10 millimeters. You can see it was over half of our cohort here. There were some 15 by 10s, and then only one instance of a 15-15 or a 20 millimeter. Clinical success was achieved in 37 patients, which was about 93%, and our duration of follow-up was 17.3 months on average. In terms of double pigtail stent placement, there was 35 instances of double pigtail stents being placed through the lambs. Most commonly, about 85%, this was a 7 French stent, and most commonly, 62% of cases, there were multiple double pigtail stents placed. In terms of characteristics, we were roughly, even between the lambs removal and the lambs left in place, with 60% of the lambs being routinely removed and 40% of the lambs being left indefinitely. For those who ended up having the lambs removed, 21% of those had planned lambs removal, 3 had unplanned, meaning that it was not a routine procedure, a patient had pain, or some indication that caused them to remove it earlier. And there was no adverse events at the time of lambs removal for lambs being removed. In terms of adverse events, really kind of what we're after, in the indwelling lambs group, you can see that there was only 1 instance of recurrent cholecystitis, which was similar to the lambs removal group. There was no instances of sepsis in the indwelling or long-term lambs group. In the lambs removal group, there was 2 instances of sepsis. Overall, you can see that there was a higher adverse event rate in the indwelling lambs group, but a lot of this was driven by either unplanned admissions, typically, for pain, rarely for, recurrent cholecystitis in that instance, or need for an endoscopic procedure. In conclusion, we found that rates of recurrent cholecystitis in the lambs removal and the indwelling lambs groups were low. This is one of the big debates about what you should do with these lambs, whether you should remove it or leave it long term, and so we found that was fairly low. But overall in our cohort, the adverse event rate was higher in the indwelling lambs group, with 56% versus 29%. Mostly this was driven by the need for repeat procedure hospitalization. And so our hope for this is that this will kind of spur further randomized studies to really look at this question and figure out what we should be doing with this, but maybe the rates of recurrent cholecystitis are not as high as perhaps hypothesized. I'll open it for discussion. Thank you guys for your attention.
I guess the patients with malignant biliary obstruction, the bile that was drained through the gallbladder did not have removal of the lambs, right?
That's a good question. So I think predominantly the malignancy associated tended to be more in the indwelling lambs group.
So malignancy associated cholecystitis. There were some biliary drainages in your series?
No. So basically there was a couple that had failed ERCP where they're trying to drain through the gallbladder, assuming that the cystic duct was paid in. So there was a couple failed ERCPs. I'll go back to that slide for you.
Because there's a recent larger registry of LAMPs inside of a gallbladder drainage. The only independent predictor of recurrent biliary events is the presence of underlying malignancy. So probably in your cohort, patients that are having the LAMPs left are different from those who are having the LAMPs removed.
It's a fair point. Yeah, like you were saying, the biliary decompression was 2 of the cases, and the malignancy associated indication was 9. So it's a good thing to think about for kind of the study and parsing those out a little bit more. Absolutely.
Thank you.
Thank you. Okay.
Thank you, Dr. McDonald. It is my pleasure to welcome Dr. Clement Wu, who will be talking to us on the involvement of more than one interventional endosonographer significantly reduces radiation dose for interventional EUS procedures.
Hi, very good morning, ladies and gentlemen, chairpersons. Thank you so much for the opportunity to actually represent my group to share the results of our study, where we actually explored the determinants of radiation dose in interventional EUS procedures, and where we found that the involvement of more than one interventional endosonographer actually significantly reduces radiation dose. So I have no disclosures. So we all know that exposure to fluoroscopy has a potential for adverse events in both patients and endoscopy staff. Interventional EUS procedures entails significant radiation exposure. Radiation safety is important, of course, for patients and medical staff. And in this study, we identified the determinants of radiation dose in interventional EUS procedures. So we prospectively enrolled consecutive patients undergoing interventional EUS procedures at the Singapore General Hospital over a 2-year period. Our primary outcome was that of fluoroscopy time as well as radiation dose. And our secondary outcome was procedure time. So we looked at various factors and we performed a univariate analysis on demographic, clinical, as well as procedural factors. And thereafter, we shortlisted various factors with which had a p-value of less than 0.1 and ran those on a multivariate analysis to identify independent predictors of radiation dose. So the participation of the additional endosonographer usually involves direct control of the guide wire and stent deployment. And as you can see in these pictures over here, we have had a long practice of collaborative endoscopy, where our threshold for actually involving another endosonographer in the procedure would be low. So in our study, we involved 62 patients, of which less than half of these patients underwent EUS cisgastrostomy. Approximately 40% of them underwent EUS guided biliary drainage, and almost 20% underwent EUS guided gastroenterostomy. We had an equal distribution of cases done under anesthesia and moderate sedation. Slightly more than half of the cases were done by 2 endosonographers. The mean procedure time was that of 50 minutes. Fluoroscopy time was approximately 600 seconds, and radiation dose was 2,200 micrograys. So in terms of our primary outcomes, we found that BMI actually was significantly related to radiation dose. We found that having 2 interventional endosonographers significantly reduced both fluoroscopy time as well as radiation dose. The involvement of a fellow, somewhat expectedly, increased the radiation dose and fluoroscopy time needed. We found that fluoroscopy time was increased in cases which were complicated, which is not unexpected. In terms of our secondary outcome, we found that the number of, or rather having two interventional endosonographers significantly reduced procedure time by the magnitude of almost half. The involvement of a fellow in the crucial parts of the case also increased procedure time. And in terms of complications, of course, a more complicated case or the presence of intraprocedural complications would be associated with a longer procedural time. In terms of the strengths and weaknesses of our study, we believe that our study is, some strengths of our study would include that of there being us having real-world data in this case. Our small pool of endosonographers also means that we have a relatively more homogeneous pool of endosonographers, and there's somewhat less variation on its effect on radiation dose. Of course, limitations in our study would include that of the small study population, and because of our small numbers, there was heterogeneity of the procedures which we included. So, in conclusion, interventional EUS procedures are known to be technically complex. The involvement of more than one interventional endosonographer significantly reduced radiation dose, fluoroscopy time, and procedure time. Of course, further studies are needed to establish its role as a radiation reduction strategy. Before I end off, I'll just like to acknowledge my two senior practice partners, and thank you very much for your very kind attention.
Do you have time for questions?
Yes, go ahead.
Thank you for highlighting something that's very important. Two questions. Did you have somebody in the rooms timing the aspects of the procedures as they were occurring in order to say that certain things did change time? Or was the time aspect of this retrospectively analyzed by nursing records, for instance?
It was actually by records, but we actually list down the timings of starts and ends of the procedure, and this is how actually we measured our procedure time. In terms of fluoroscopy time, of course, this would be measured on the fluoroscopy machine.
The second is more of an editorial, and I'd be interested in your thoughts. It's often hard to get two doctors together for the same procedure.
Yes.
And we don't use two doctors for most of these procedures. Instead, use very well-trained nurses. Perhaps fellows will help with certain parts of the procedure. Do you think the same data would occur if you had perhaps experienced nurses who are familiar with these procedures instead of calling another physician in because of the obvious, problems with time and things like that?
Yes, that is a very good point. And of course, it does illustrate the differences in practice environment between that of the US and perhaps East Asia and the antipodes. In this case, we are actually looking at very complex procedures in terms of nursing staff which are trained up to that level. Perhaps it's this is somewhat harder to come by. But yes, definitely a very, very well-trained nurse or a very well-trained tech should have similar results, or we will expect similar results in that case too.
Congratulations, Giuseppe Vanella, Milan, Italy. What is the role of the procedure itself? Because we did a work on this in the past, and we found that hepatogastrostomy had much higher radiation exposure than gastroenterostomy, much higher than choledochoduodenostomy, much higher than fluid collection drainage. Do you analyze this data?
Yes, we did. But of course, you know, in terms of the very small sample size, we didn't think it was actually meaningful to break these down further. But you are right. In terms of radiation dose, if we were to compare between the three different procedures, EUS-guided biliary drainage as well as gastroenterostomy would have significantly higher doses compared to cisgastrostomy. And in fact, in many centers around the world, we are performing cisgastrostomy without fluoro guidance. Thank you.
We're going to leave you in suspense for 1 minute for Dr. Arain's state-of-the-art presentation, but I believe there was a question for Dr. Sato that we weren't able to get to earlier, and I didn't know if that question was still wanting to be addressed.
All right, so the next one we're going to move forward to the state-of-the-art talk, and then today we have a pleasure of having Dr. Arain Mustafa to give us and shed a light on the biliary drainage and then the EUS biliary techniques in 2024. Dr. Arain, currently he works at the Orlando Health Group, and he is one of the first few ones, right? Advent Health, and then he is one of the first few ones who train us, right? And then the first few ones who does the rendezvous EUS CRCP in the world. Yeah, welcome, Dr. Arain.
Thank you. This is a distinct honor and privilege to be presenting a state-of-the-art accompanied by such big names in the field. So thank you to the organizers. Here are my disclosures. I will be discussing off-label use, which we've been doing all morning. And I want to just acknowledge this diagram first, because Dr. Perez Miranda, who's in the audience here, published this. And every person who looks at it when I'm presenting tells me what an amazing image this is. And I think it really summarizes the different approaches that we have. I've taken the liberty of adding number 7, Manolo, if that's okay. And I left out the pancreas. But essentially, this gives us an idea of the different types of approaches that we have available. And if you go down the list, number 1 is creating a hepatogastrostomy, and you're draining it into the liver, into the stomach. 2 could be 2 different approaches: a rendezvous approach where you advance the wire and then you complete the ERCP, or you actually do an antegrade stenting. So that's number 2. 3 would be choledochoduodenostomy, and what's not shown is also you have access to not just the bile duct, but also the right lobe of the liver. And by extension, in altered anatomy, you could be coming from the jejunum into the right lobe or the left lobe. And then 7 is gallbladder drainage, which could be transgastric, transduodenal, or even transenteric in altered anatomy. So it's not one approach we're talking about. We're talking about a heterogeneous sort of approach to managing these patients, and each carries different sort of complexity as well as risks. A brief history. The first sort of approach, the choledochoduodenostomy, was first reported in 2001. First EUS-guided hepatogastrostomy was in 2003. All these patients were treated with plastic stents, and remarkably, they did not have any leakage. Following this, the first biliary rendezvous report came out in 2004 by Mallory and Freeman, who I had the honor of sort of being trained by. And then, if you look at the number of randomized studies in this field, they're very limited. So Artfan and Gupta et al. Compared EUS-CD versus percutaneous biliary drainage. Itoy and Bin Moller then described their lumen-opposing stent as a viable option, followed by a Korean study using a different SEMS, which was electrocautery-based, versus conventional SEMS for biliary drainage. So if you, on the other hand, if you look at the, just to give you an idea of the biliary rendezvous, essentially, It's a multi-step process. We start with, I just want to make sure my slide order is correct. I think I'm missing a slide, for which I apologize. But I wanted to show you the number of randomized trials that have been done in the subsequent decade, which unfortunately for some reason I've lost those slides. But essentially those studies, authors of which are in the audience today, I would have liked to have highlighted, but have shown that in the last decade or so we have had a shift in the approach, and we're actually looking more and more in more sort of randomized studies rather than just case reports. So going over the biliary rendezvous approach, this is a multi-step process. You have to access the bile duct using an EUS scope with a 19-gauge needle, typically contrast injection, wire placement, and then there's a scope exchange process followed by biliary cannulation via ERCP and stent placement, as opposed to a Lamb's approach for distal malignant biliary obstruction, where you're basically using an EUS scope to access the bile duct by initially injecting contrast, if you choose to do so, and identify your stricture. And there's debate on whether or not you should do it freehand versus wire-guided, but in this case we went freehand after that because it was a very dilated duct, and you can see the Lambs will be advanced under fluoroscopy into the bile duct. This is your key moment because this is where things can go wrong, but again, in a larger duct, hopefully things should go okay. Here we advance the stent, and you see nice biliary drainage. Actually, no, I guess my order was okay. I was just not remembering. So basically what you saw was with the Lambs being introduced, there was a explosion of studies. And what most of these studies consist of are case reports, case series, some sort of comparative retrospective studies, and I'd argue maybe in the last few years, a lot of meta-analyses discussing the same data. But what we really wanted to know is what are some sort of high quality studies. And if you look at that, the Korean group has published some studies, and there's been a shift not just for failed ERCP, but now towards primary drainage. This is a recurring theme over the last few years. Dr. Teo, who's in the audience here, has sort of taken the charge, as well as Yanni Chen, and both of these studies were presented earlier this week, looking at EUS versus ERCP for unresectable malignant biliary obstruction, with EUS being a primary approach. And then we come to this landmark study. I think Dr. Thier, his perseverance with a randomized trial on EUS rendezvous versus ERCP pre-cut, taking us back to ERCP to say, hey, wait a second, what is the role of ERCP? And he's already presented this data. I just want to highlight a few things, including patients who had inaccessible papilla. Their cannulation rate was 85%. But if you exclude the patients who had duodenal obstruction, inaccessible papilla, their cannulation rate was 94%. And so what this highlights is the vast majority of patients can still be accessed via ERCP. So what we're discussing here is the 5 to 10% of patient population, but let's not forget the vast majority of patients can be accessed via ERCP. What he found was that actually in terms of outcomes, there was no significant difference, and that both approaches are feasible. And as he highlighted in his talk, that they use the 5-5-2 rule, which basically, if you look at the ESG guideline and you look at that left green column, that's the pathway that they went down. But there is that whole right-sided pathway where, as he mentioned, that they did not put in PD stents, they did not use some of those pancreatic access techniques, and perhaps with those techniques, the cannulation rate would be higher. So if we were purists about ERCP, which is not the purpose of this talk, but if we were, then perhaps we would be having higher success rate with ERCP alone. So this is just a counter argument. The other interesting sort of talk came from the Dutch group, and what they showed us was that transpapillary endoscopic drainage, when compared to EUS guided drainage, there were when they did a controlled for both groups, what they found was that the overall complication rate was similar, as was the pancreatic fistula rate. It's interesting to see that some of the other outcomes seem to be better in the EUS drainage group, and we'll see, I'm assuming that they'll be conducting a prospective trial on this. So this area will be interesting to see that does EUS-guided biliary drainage actually lead to better outcomes in surgical patients? That said, again, the number of patients going to surgery is still well below, I would argue, 15%. The other thing was the surgeons didn't necessarily seem to care. Though when in clinical practice, when we talk to our surgeons on a day-to-day basis, they're like, oh my God, please don't do this because it's going to totally mess up our surgery. But it turns out that perhaps it's not as bad as it's made out to be. Okay, so what about LAMS for malignant biliary obstruction? Is it really all, this rosy picture that we get to see? And I just want to highlight this case, recurrent biliary obstruction despite plastic stent through the LAMS. And this patient had 2 episodes, following which we thought, okay, we have to do something different. So we went through the LAMS and went antegrade across the stricture. At that point, we put a SEMS antegrade through this stricture, and now you have double drainage. You have the choledochoduodenostomy, and you have an antegrade drainage for biliary, for the bile duct, and subsequently still put in double pigtails across the LAMS. And this patient, for the rest of the duration of his life, which was 6 months, did not have any recurrent episodes. I think there is a reason Mother Nature put the bile duct orifice where it did. And I think while I'm very enthusiastic of LAMS in the right setting, something has to be said about the fact that antegrade drainage seems to be preferred. So what our approach tends to be is if we can get to patients via a antegrade approach, especially if they're considered to be endoscopic surgical candidates, we'll do this. This was a 32-year-old female with adenocarcinoma referred to us after a failed ERCP due to adrenal obstruction. And here we accessed the left lobe of the liver, advanced a wire across the stricture into the duodenum, following which antegrade placed a biliary metal stent and then placed a duodenal stent. And the patient subsequently underwent chemotherapy and a Whipple resection and was doing well at 1-year follow-up. So what about this EUS-guided antegrade / transhepatic approach? So you have your EUS scope, you have to gain access, contrast injection, wire placement, and these can be in various orders. Sometimes people prefer not to put in a contrast and go straight with the wire, not to sort of make it sticky. But irrespective, get the wire either across the stricture and then deploy a stent, or leave this wire in place and place a transgastric stent. And some of the issues that we run into may include not being able to get the wire across the stricture. And in this situation, we're using a blunt cannula as opposed to cautery-assisted cystotome, and just working our way with pressure. And eventually, as you'll see, we go across the gastric wall into the biliary tree. And following this, the wire is repositioned into the duodenum, and a stent is placed. So now you can do your antegrade drainage. Okay, and let's not forget benign disease, because this is an overall overview of EUS biliary drainage. Patient intraoperative cholangiogram positive for bile duct stone. The surgeon walks in and says, hey, the patient's still asleep. Can you do an ERCP? We have the family member who can consent. I'm like, yeah, sure, we'll do it. Shouldn't take very long. We go ahead, get consent, do the ERCP, and lo and behold, it's a 2-hour procedure. Pancreatic duct access, double wire technique. We're going down the algorithm. Pancreatic duct stent placement, and then needle knife over the PD stent, right? That right column that was shown earlier, and nothing. Ended up doing a rendezvous intra-procedure, small duct, wire goes up first, get it to go down, get across. Finally, obstructing stone at the papilla. We basically did a rendezvous sphincterotomy, stone removal, stent placement. So in benign biliary disease, as long as it's not post-operative, say post-Whipple, our goal is not to necessarily create new orifices, but actually drain them, especially when it comes to the bile duct, while maintaining the anatomy. Okay, so moving on to gallbladder drainage. Here are some key trials or studies. I wanted to mention both the Barron and the Kwan study because they were literally 1 month apart in GIE, and I think they both ought to deserve credit for first cases presented. Then Dr. Teo and Winmoller presented the first gallbladder drainage via LAMS, and of course Dr. Teo's landmark study, the randomized trial of gallbladder versus percutaneous drainage, which really shifted, at least we were convinced, but the radiologists needed convincing. And it convinced them that, maybe endoscopic drainage is better. Then there was this interesting study last year of ERCP plus gallbladder drainage with LAMS versus ERCP alone for distal malignant biliary obstruction and cystic duct obstruction. So if on imaging you have cystic duct obstruction, go ahead and primarily prophylactically put in a LAMS. And what this showed was that those patients who had their LAMS put in did better than the ones who did not in terms of cholecystitis. This is a bit of a it's a bit of a revolutionary approach to gallbladder management. And as if that was enough, Dr. Manuel Perez-Miranda now applied the same principle to benign disease, and that study was published earlier today. I don't have any slides on that, but to say that it's an interim analysis and the results are interesting. They seem to be favoring drainage of the gallbladder versus not. So how does gallbladder drainage work? This is a patient who actually had this is not benign, this is a malignant patient who previously had a partial gastrectomy, and this is actually across the jejunum into the gallbladder for cholecystitis. And you can see the gallbladder is accessed freehand, the stent is deployed, and then you'll see some drainage of some chronic sort of standing fluid in the gallbladder. And here the approaches vary in terms of what do you do next. Do you just leave the stent or do you balloon dilate it? Do you balloon dilate and put a stent? On a personal level, my approach is to balloon dilate and put in at least one double pigtail stent. If the patient's critically ill, ICU type of situation, put in the LAMS, put in double pigtail and get out. So here's a Dr. Teo study, and the key sort of bars are the blue ones at the top, which clearly show significantly reduced adverse event rates in the EUS guided gallbladder drainage compared to the percutaneous drainage arms. In terms of technical and clinical success, both percutaneous and endoscopic work just fine. This is a case I actually presented a couple of days ago, and I just want to quickly run through this for those in the crowd who may not have been there. But essentially, not every gallbladder drainage goes well. We've seen two studies today with respect to recurrent problems, but this is a patient, significant comorbidities, who ended up getting a gallbladder drain for cholecystitis, got resumed on his anticoagulation, and then comes back with an INR of 7 and dark stools. And on CT scan, you can see that there's a hematoma inside the gallbladder. Was taken for endoscopy, difficult procedure, had stents placed. Unfortunately, continued to do unwell and had to have percutaneous drains put in. He sort of survived that ordeal, but the kicker is when 2 months later he came back, both the plastic stents and the LAMS had all migrated out spontaneously, and we were back to square one with the percutaneous drain. And we had two studies on what should we be doing in terms of leaving these stents, not leaving them, going after the stones or not going after them. And I think of the two studies that the Hong Kong/Spain group had a very nice sort of matched analysis. What's interesting is that what they showed was that maybe not going after things is a better approach than doing things. The US study is 40 patients, and I sort of congratulate the authors on getting this going, but I do think we need higher numbers and we need a statistical analysis because I don't recall seeing any p-values over there. And I also want to bring our attention to this study, which is a study by the Thailand group, which looked at a similar approach that has been adopted by Dr. Manuel Perez-Miranda. Instead of doing EUS-guided gallbladder drainage, what they said was in the pandemic, there was a delay in cholecystectomy. So what their approach was, let's go after the gallbladder in everybody. And these patients included acute cholecystitis. And what's interesting is that their success rate for accessing the gallbladder using this approach was 100% in the patients in whom they tried it. Some of them they needed to use cholangioscopy, but they were able to get across and put stents in. And at short-term follow-up at 3 months, which was their primary goal, there was a significant difference in the number of recurrent episodes of cholecystitis as opposed to those who did not get the gallbladder stent, highlighting the role of ERCP. Let's not forget about adverse events. We've heard about those. We're crossing natural barriers, and so the stakes are higher, and bleeding, peritonitis, all these different injuries that occur can be significant. If you want a ballpark figure, carry 15% with you. It may be 8 to 15, it may be 15 to 20, but the real number is around 15% in expert hands. So we have to be cautious about the risks. And then there's an element of unpredictability and lack of control because we don't have control on that other side. So that's something to keep in mind with EUS-guided approaches. And then unseen risks. We heard a bit about radiation exposure just now, and I'd just like to comment 2 comments. We looked at our data in the setting of necrotizing pancreatitis and radiation exposure because these patients are getting repeated procedures, and the exposure rate was through the roof. Secondly, what's more important than exposure is effective dose. Exposure just means literally what you're getting exposed to. Effective dose is what's the actual damage being done. If you think about it like a wind, if you're standing behind a window, you're exposed to that wind, but the window is the barrier and you're not feeling it. But what really matters is how much of that wind through the holes in the window is coming through and affecting you. So I think for the authors, it's a great study, but I would convert the radiation dose into effective dose. And that's what's going to give us the real value of that study, which will clearly show that there are risk factors associated with radiation in these procedures. So how should we, or in my mind, not necessarily everybody's, but my mind, be approaching these patients? We should be thinking about the anatomy. Is it natural versus post-operative? Is it benign disease? If so, should we be preserving anatomy, especially when it comes to the bile duct? Malignant disease, is it resectable, unresectable? Unresectable, we have a better a broader playing field. With resectable disease, should we be being more cautious because these patients, potentially may have adverse events from our procedures which may affect their surgical resection. The level of biliary obstruction is critical, hilar versus distal. And then there are other factors, patient-related factors, such as ascites, vascular anatomy, portal vein occlusion, and varices. Those factors may play a role in what approach we take. And then there are the procedural aspects. Endoscopists experienced with ERCP and EUS techniques, should it be only EUS-trained people doing EUS biliary drainage, or should they be trained in ERCP-related procedures? Because there is overlap, there's radiation. And device and stent familiarity, indication, how necessary is it? I did an intraoperative ERCP that we could have woken up the patient and done it the next day. That said, fortunately the patient did well, but anticipating setting up expectations for the patient and their family, and also going into a patient, reviewing the CT scan and realizing, this is a high likelihood for requiring biliary drainage versus ERCP. Being familiar with troubleshooting techniques, dealing with complications, and backup plan. This is extremely important, cannot be emphasized enough for any interventional procedure. If things go wrong, you're about to stick the liver from the stomach. If you don't succeed, what is your backup plan? Is IR on board? Is it 9 o'clock at night or is it 8 in the morning? Those factors matter. And then finally, technical success does not equal clinical success. We've seen that in some of the data that's been presented, as well as some of the cases that I showed. So mastering EUS biliary drainage in 2024, which is a very lofty title. Most biliary diseases requiring drainage can be managed by ERCP. That's my first point. Shifting paradigm, ERCP instead of EUS instead of ERCP. Natural orifice drainage versus new orifice, is it absolutely necessary? I would argue in most patients not, but yes, there is a subset that we are discussing here. Is ERCP really that bad? Maybe, maybe not. SVI seems to have reversed the tide in terms of PD stenting and going back to believing in stents. And we have biodegradable stents. A lot of those factors that related to ERCP-related complications, maybe in the future we'll have options that minimize some of those concerns. I think knowledge of EUS and ERCP techniques is important. If if in doubt during a procedure, it's better to stop. And I think that comes with experience. All of us who've been through this may sometimes push the envelope, and as time has gone on, realize, you know what, this is where I'm actually going to stop. We'll come back another day. Future directions, optimization of tools and techniques. We're getting there, but we're not quite there yet. Permanent fistula creation, maybe biodegradable stents for EUS, who knows? Stent-free anastomosis, endoscopist training in these techniques, radiation exposure, various aspects. And my final point, this is just the beginning. We're not quite there to claim mastery just yet. However, the future of endobiliary therapy with EUS is very bright. Thank you for your attention.
The floor is open for any questions.
Mustafa, that was an amazing state-of-the-art talk here. I just want to underscore the importance that mastery of EUS biliary drainage requires mastery of ERCP first. These must be interlinked. They must be truly married together. EUS biliary drainage can never be an alternative to poor ERCP skills. So that's my plea. I think it definitely has a role. There's no question about that, but it must always be complementary.
Thank you. Thank you so much.